try to get a 3D stretch of the hamstring rather than just a sagittal plane stretch of the hamstring. That is the same for, you'll see it come up. So here, adductor assessment and treatment. This is still using the old Yonder model of the modified hip flexor test. It will show me tightness of the adductors, the hip flexors, and quadricep and tensor fasciae lata, depending on the reading I get from the position of the femur and the orientation of the tibia. Just adductor, looking at the ease with which you can straddle, and if the patient can hardly straddle your Brits, you're probably looking at some very tight and adductors. Using the tripod is one way again of assessing adductor length and being able to compare it side to side. Using the passive hip flexion in supine with the knee bent is one way. This is just me showing you a stretch of the lateral posterior line all the way through for the hamstring. Again, a dynamic stretch for the hip flexor, where you are going to rotate a little bit and shift side to side with, in this position. You don't have weights or anything like that, but you get the idea. So instead you'd be like this, and then you'd rotate this way and you'd shift side to side to get a more dynamic stretch. This is the stretch of the hip flexors, which is good because it helps me. I can force the spine to be vertical or in line with the thorax through the non-stretch leg, and I can let the patient use the support fixed point to bring the thorax in line with the pelvis and keep the stretch so that it doesn't escape, so that the person doesn't escape. Okay, this is a stretch over a roll. It is important that you remember that the correctus is not always tight uniformly. It can be tight at the top, in the middle, or the lower part. When you have the patient prone and you bend their knee and you palpate, you will find out where the tightness is. If it is in the upper part, you can use a foam roll like that, sit on it and lean back, and you will feel how tight it really is here and not at the knee. So if you have a proximal contracture of the hip flexors, you have to put the fulcrum of the stretch close to where it is tight. Doing this will not do it because you will accommodate for that tightness. Okay, so that's what. Yes.
Using that fulcrum though, going backwards, right? You were concerned about maybe pushing the femoral head forward.
I know you will. That's why I have my hand supporting me, and I'm just using enough force to feel the stretch. I'm not like leaning into it and pushing it. And when I finish, I would reseat my hips by bending forward, or even you can reset it by using a band. You lean into the band and lean forward, and it will push the femur. You'll see the exercise coming up. So it is always important to have a way of self-repositioning your hips. Yeah. So this is treating the tensor fasciae lata by extending the leg from the tripod even further into the position and rotating away from the stretch leg. We'll get a good tensor fasciae lata stretch of the anterior glute med, and so on. So the IT band syndrome, if you need to release the tensor fasciae lata as part of it, or the medius, this is what you would use. However, I think from the work of Chris Powers, I think it is, he is showing that valgus, when you have an IT band syndrome, you should look for the drop of the pelvis is what pushes the leg out against the IT band, yes, as opposed to a valgusing of the knee, which is different. You will get more knee pain problems, and probably you can get lateral pain problems, but they will probably be related to the short head of the biceps, and you have medial problems related to the medial structures being overstretched, medial collateral ligament, retinaculae, and the meniscus, etc. So that when you have a Trendelenburg type weakness, then the IT band may take the strain and become problematic. When you have a weakness into valgus, where the compensation is valgus of the knee, you'll get more knee problems that are not related really to the IT band. So the goal is to treat it. Of course, we know some of the reasons for knee problems, so these you can read over, like excess varus angles. We all see this, the alignment. So when it comes to looking at the patellofemoral syndromes, we have to look at the patella in relationship to the femur orientation and the alignment to the foot. So it can be a top-down or bottom-up problem, and we need to know what is the muscle imbalance around it. So we see often meniscal subluxation irritation, and as I've told you before, it usually it can be a traumatic incident, or it is over repetitive abnormal position of the knee in torque or torsion positions. Pain with weight bearing and stance phase of gait may be there. The palpate and you may also see that the patient starts to lose full extension of the knee. They are standing with a little flexion most of the time, and they can no longer complete their gait cycle because the knee is painful to extend or hyperextend. You have quite telltale signs of a meniscal and knee internal irritation, and those are trigger points of the tensor lata muscle, of the popliteus muscle belly, of the medial gastrocnemius, of the anterior talofibular ligament of the foot, of the ankle, and you may see anteromedial, anterolateral joint line tenderness, and often there is edema either in the front of the knee, or the Baker's cyst will be also present. Okay, so those findings are usually going to be there, and you are going to use them as your baseline for monitoring the treatment of the knee, and also the degree of pathology that you have. So if you treat and these baseline symptoms disappear, that's a good sign. If they return almost to the same level by this next visit, that's a bad sign. If they return a little bit, that's a good sign. So, if you have a meniscus tear, whether it is confirmed by a radiograph or not, these signs can tell you if it can be managed clinically, or if it's not, it will have to be managed surgically. Because if the baseline symptoms keep returning, chances of success start to go down. So we will look at that. So you are looking at the menisci in 3D at the condyles with the patella in front, and so the torque often of femur on tibia destroys the relationship and overloads these structures. So this is the manipulation, mobilization of the meniscal derangement or subluxation, and then the recheck of the symptoms. this chronic torquing can be also seen as causing some knee discomfort, and you can look at directional treatment for choice of exercise. So if I have, for instance, a person with knee pain, it may not be acute, but it is nagging knee pain, and I'm giving them exercise. Sometimes it is important to know the exercise must be biased to de-rotate the torque in the knee, and therefore you must test this torque function in the knee and see if it is a player, and then the exercise must be administered accordingly. So here we have, for instance, I want to maintain the external rotation of the femur, whilst I encourage internal rotation of the tibia. Many times we can see this. Sometimes there are contracture. I remember in the work of when the foot hits the ground, they would talk about medial genicular rotation, and if it was missing, you would restore it. Well, you can test for it both lateral and medial and restore it accordingly. So you may find that the patient is suffering from both femurs falling in on the tibia, or one falling in and one being twisted out. And then they will both need different stress treatments to relieve the knee pain. So that is doing the internal rotation of the tibia on the femur after I have mobilized the knee. And this is somebody with bilateral internal rotation. I'm just giving her a simple home exercise because it is not possible to give more complex exercises in a DNS method. You can do it, but you'll have to be there to oversee that it is well done until they get the hang of it. But if you are just going to give them something to do to tide them over, then this is not a bad exercise to do, because this requires glute activity, external rotation function of the femur, internal rotation function of the tibia, and active foot, an active forefoot loading. So that's it. Another thing that is, I think, of interest is distraction of the knee. If all the many joints, the knee is the only one with a pad between it. Yes. So the risk for contracture of that joint space exists, more so than in a joint that has no pad and is just already close packed. But the knee has much more laxity. And sometimes, as you get older, this chronic compression just tightens everything. The muscles are pulling and compressing the knee and compressing the knee. And it can become painful and impossible to use the knee. Many old people have just this compressive force in the knee, and they cannot bend it, they cannot use it, it is painful. And one of the things you can do is to start to distract the knee using a towel. And especially if you have degenerative changes in the knee, it is hard to use it if it is all contracted and rough. Yes, so you can use a towel roll to start distracting and stretching the articular complex. And here I'm doing it like this, and then I'm sitting back and slowly improving that. Along with that, you will treat the proximal head of the gastrocs, because they can be very tender and they will block flexion of the knee. So that's it. And then for the VMO activation, you can press the shin into the table. I push against the wall. That activates the VMO. I'm so far bent over, the rectus femoris cannot participate significantly. So this can be a nice, easy way to start activating vasty muscles, not VMO alone, all the vasty muscles, whilst the rectus is toned down, yes? Going from kneeling to high kneeling, using the vasty muscles, leaning back as they get stronger and you tolerate more, the vasty muscles will have been stronger. Now you can start using the whole rectus quadriceps muscle to eccentrically work around the knee. So this is good for people who are recovering from knee problems, and because even just this isometric position does not, the isometric position is very low, it does not require much movement. So once the patient can get into this position or even a little higher, just getting off the support if they're sitting on a yoga block, just getting off the support will activate and they can sit back on the block. Activate, relax, activate, relax. And that is a nice way to start it off. And you can use a towel to open up the joint space at the same time. So these are useful activities for both the lower limb and for the pelvic control. So I'll break there and we can